Hey guys, welcome to this pharmacology review on the drug class Selective Serotonin Reuptake Inhibitors, also known as the SSRIs. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from the what to the why. The SSRIs have been available since the late 1980s. They were developed in response to problems that arose out of the monoamine oxidase inhibitors and the TCAs. Fluoxetine, also known as Prozac, was the first to be introduced in the US, and that paved the way for a rapid growth of agents within this class. In my 30 years and experience working as a nurse, pharmacist, and physician and teaching in academia, I've been able to watch this class in particular unfold and become one of the first-line treatment therapies for major depressive disorders and other anxiety-related disorders. Now, there's a lot to be learned in this drug class, even for those of us who have seen and used them over the years. There are some clinically relevant issues associated with them that, if ignored, can lead to bad outcomes for the patient. All right, so let's talk a little bit about why it's so relevant to learn about the SSRIs. Well, they are, for the most part, first-line treatment options for depression and anxiety. With the exception of Citalopram and Escitalopram, they also have a very good safety profile because of their large therapeutic index. Basically, if you overdose on them, not much is going to happen with the exception of those two drugs, Citalopram and Escitalopram. That becomes a problem, which we'll talk about here in a minute. All right, so what are the medications that make up this drug class, and what are some of the common uses? And I want to point us to a table that helps us to see them compared to each other and to summarize some of the key points of this drug class. Now again, these tables are very similar to other topic reviews in the drug category antidepressants to give you some context. All right, so you can see from the table, it's obviously got a lot of information in it. I'm not expecting you to be able to absorb all of it or read all of it right now, and it may be difficult to read on the screen. That's okay. We're going to walk through the key points, okay? So I'll talk about it. On the far left, you have the drugs, and they're listed by generic name predominantly. You see that they have some of their branded names there for just context and perspective. So we have Citalopram, we have its enantiomer, Escitalopram, Fluoxetine, fluvoxamine, which I don't see much used anymore, Paroxetine, and then lastly, Sertraline. And then if you look to the right, you can see a lot of the common indications and uses in real-world clinical practice. So it's not just major depressive disorder. You heard me talk about anxiety disorder. Things like, if you hear social anxiety disorder, general anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder. It is also used for augmentation in bipolar depression, which means that they're on a mood stabilizer, and then you can use these drugs. Bulimia, okay? So you see there's a long list, and all these indications are in part why their use is so strong in clinical practice and why you see a lot of these drugs on patients' medication profiles. I even want to point out down here there's vasomotor symptoms related to menopause, okay? So just a large number of options. Now what you don't see in there, which I think is important, especially as you kind of compare indications with other drug classes like the SNRIs or TCAs, you don't see pain syndromes in there. You don't see that, like the fibromyalgia, musculoskeletal pain, neuropathic pain, you don't see that. And so that may point, again, when you look at the target neurotransmitters, there's really not much going on with norepinephrine here. It's primarily a selective target for serotonin. We do then have other targets, which we'll talk about here in a minute, but I want to step away for a second and walk us through what is happening at the synapse in the central nervous system. Okay, as it relates to the mechanism of action of antidepressants, we're going to just think about it as a class, a category. There's a lot of things happening in the central nervous system. There's a lot of nerve fibers that are talking to each other in different tracts in different regions of the brain. And this is part of the reason why some drugs, when they modulate the activity of one track, we see a benefit or an effect in a certain type of condition, but if we isolate that effect in another track, we don't see the same. So that gives us some variability, and that's why you see some indication variation inside of the drug classes of the category of antidepressants. So for example, SNRIs and TCAs, which mechanistically are similar, can treat some pain syndromes. You see that common shared thing. Whereas SSRIs, Selective Serotonin Reuptake Inhibitors, we're not using it to treat pain. It's mostly anxiety, depressive disorders, those kind of things. And so let's step into what's going on inside of the brain at the central nervous system where these drugs are working. So what we see over here are two neurons interacting, okay, and then they usually communicate obviously by an axon, and in between their connection points is a synapse, or synaptic cleft is what we refer that to. So this picture that we're looking at larger is kind of zoomed in on this region right here. We have the presynaptic neuron where the impulse is coming down from the axon. It then facilitates intracellular and chemical reaction that facilitates the emptying or the release of neurotransmitters. So you see these vesicles that are floating around in the presynaptic neuron, and those vesicles are holding on to neurotransmitters. And those neurotransmitters are the serotonin, norepinephrine, and can also include dopamine, okay? And so we have different vesicles for different neurotransmitters. This drawing a diagram doesn't necessarily reflect the difference in those, but just recognize that those are the neurotransmitters housed in that. Well, you see that calcium is necessary, its influx in facilitates the binding and the merging of the vesicle at the presynaptic neuron to empty those neurotransmitters into the synaptic cleft. What's the purpose? To then stimulate the postsynaptic neuron that's going to drive the impulse to the next neuron as it propagates through the system. Now, you see on the postsynaptic neuron in the synaptic cleft there's a number of receptors, and these are receptors that drugs can bind to directly. So we have some drugs that act as agonists to these receptors, and you see that these neurotransmitters get in and then they turn on and create the propagation of the nerve impulse moving forward through a number of different mechanisms. There's a lot of different types of transporters here. Okay. Now, when these neurotransmitters get released into the synaptic cleft, yes, they can bind to these transporters and turn on and propagate the nerve impulse, but they can also be taken back up by the presynaptic neuron. So that's where reuptake occurs. So when we think about these SSRIs, serotonin Selective Reuptake Inhibitors, those drugs would prevent the reuptake of serotonin neurotransmitters. Well, what would that do? That would leave more serotonin neurotransmitters present in the synaptic cleft to exert more of a pharmacologic effect on the postsynaptic neuron. So you can have, the release of it and then the reuptake of it. There are enzymes present that are not seen here, but there are enzymes present in the synaptic cleft that can metabolize or degrade the neurotransmitters, make them go away, right? So you can take it up and take them away. You can metabolize them and take them away. Or they could go in and bind to the receptor and be occupied and are no longer in the synaptic cleft. Lastly, we do have other presynaptic receptors that are not seen here, but let's just envision like there's an alpha-2 receptor presynaptically up here. Well, there's drugs like mirtazapine that functions as an alpha-2 antagonist, okay, that is, in the antagonism of that, actually increases the release of neurotransmitters. So some drugs work to facilitate the release of neurotransmitters, some drugs block the transporter uptake, and some drugs like monoamine oxidase inhibitors block the metabolism of neurotransmitters found in the synaptic cleft. If you co-administer multiple antidepressants, that is when we can see an accumulation of neurotransmitters in the synaptic cleft that raise the concentration so high that patients now can experience greater risk of side effects. It doesn't mean they all will. Sometimes we do use augmentation or adjunct therapy with dual antidepressants from different classes to manipulate the concentrations of neurotransmitters, but it does increase, obviously, the side effects. When we think about the monoamine oxidase inhibitors, that's an enzyme. And monoamine oxidase metabolizes several neurotransmitters in the brain. So let's go back to the synaptic cleft. If I block monoamine oxidase that's present out here, then these neurotransmitters can be present at much higher concentrations. Well, the thing that's about monoamine oxidase inhibitors is it's irreversible inhibition. For the life of that enzyme, it's gone. So the body has to make more monoamine oxidase enzyme before it can come in here and start to metabolize that more effectively. That's the reason why we have to wait 14 days after stopping the monoamine oxidase inhibitor before starting another class of antidepressants. If we don't, then that enzyme is not working and we increase the concentration in the synaptic cleft, it's going to exert a more noticeable effect by those neurotransmitters. And that could be good, could be bad. In this case with monoamine oxidase, we do not recommend doing that. But that makes sense of why we need to wait a period of time. Think about antidepressants and you're going to switch to a different class, like monoamine oxidase. You wait 7 days. You want to make sure that drug is gone, especially with high-risk medicines. Now again, some medications can be used in augmentation on purpose, but that's usually done by specialists and in careful scenarios. But we do want to watch out for that because of risks of things like serotonin syndrome and other things. You can lower the seizure threshold. Any drug that increases norepinephrine in the synaptic cleft is known to lower the seizure threshold. And so when you look at things like drugs like bupropion, right, even venlafaxine, desvenlafaxine, that are going to raise that norepinephrine up as well, tramadol, which has some SNRI-like activities, all of those drugs modulate, influence the neurotransmitters present. So when we study the drug classes inside the category of antidepressants, we need to have this frame of reference. Are we increasing the release, like mirtazapine is doing? Are we preventing the reuptake, like SNRIs, SSRIs, right, tricyclics? Or are we blocking the metabolism of the neurotransmitters, like our monoamine oxidase inhibitors? All right, so hopefully that overview of what's going on in the synapses, especially being a serotonin selective reuptake inhibitor. So it's impacting it's inhibiting the reuptake. So it's not increasing the release of anything. It's not causing secretion of anything. It's inhibiting the reuptake. So the concentrations of serotonin, being the target neurotransmitter, is selectively increased inside that synaptic cleft, okay? So it just sticks around longer. Now you see that there's other targets here, and I want to point out the ones that impact the sodium channels in particular and some potassium channels. That is where citalopram and Escitalopram become a problem. So this is where patients, if they overdose, can experience QRS widening or QT prolongation that can lead to malignant ventricular dysrhythmias such as torsades. And so in an overdose, it can be very relevant, okay? And that's where the therapeutic index is not as great for those two, but as a class of drugs as a whole, they're fairly well tolerated. There's a couple other targets that are very subtle. There's a sigma-1 subtype that sertraline can target, muscarinic receptors by paroxetine, norepinephrine. Again, these are subtle variations between the drugs, little nuances. I don't know that they will make it to a lot of board exams. Some specialty board exams might pick apart on those ideas and nuances, but for the most part, we just did that to help further separate some of the things that have evolved in the literature over time. It's hard to say what it means clinically. The next column over here you see, and we'll come back to side effects as a general class review here in a minute, but you can see that nausea, vomiting, especially in the acute phase of starting these drugs, is relevant. There's a lot of serotonin present in the GI tract, and so it's not surprising by that can happen. Sexual dysfunction is probably the #1 problem in this class, and that can decrease libido, changes of ejaculation, all these things can happen that can be prohibitive and cause problems in relationships. There's also SIADH. We saw that same kind of issue come up with the SNRIs, venlafaxine and desvenlafaxine, especially in our geriatric patient population, but in cases up as high as 32%. So this is SIADH, a syndrome of inappropriate antidiuretic hormone that can lead to symptomatic hyponatremia. We talked a little bit about the QT prolongation, especially with citalopram and S-citalopram. And then the SSRIs have been linked to a condition called persistent pulmonary hypertension of the newborn, PPHN. Historically was linked predominantly to paroxetine, and that's probably one of the reasons why it's not used in pregnancy. Sertraline is considered preferred or first-line treatments in pregnancy. So just kind of keep those little nuances in mind. We put a few clinical pearls here in the last column. You know, all antidepressants take weeks to reach their maximum effect. They can start seeing effects within the first two weeks, but really it takes about 6 to 8 weeks for that maximum benefit, if it's going to be there, to be there. If you're going to use an SSRI, just like any other antidepressants, make sure this patient doesn't have undiagnosed bipolar disorder, because one of the problems with this drug is that if you use it patients in the depressed phase, you can move them into a manic phase. You can even exacerbate their anxiety. While it's used for anxiety disorders, panic disorders, and things like that, if you start out too high of a dose and you titrate too fast, these patients can experience problems. The other thing that I wanted to point out here is with fluoxetine. Fluoxetine has a metabolite, norfluoxetine, that can stick around for 4 to 6 days. Well, that's good if you miss a dose. It's very forgiving. If you stop the drug, it's self-tapering. It's not good if you're experiencing a side effect and you need to stop that side effect from happening. So just kind of keep a few of those things in mind. The last thing that I wanted to point out here, and I'll come back to later, is that fluoxetine and paroxetine are very strong and relevant inhibitors of cytochrome P450 2D6, and that can lead to drug interactions. A lot of psychotropic medications go through phase 1 metabolic pathway, cytochrome P450 2D6, and so you do need to keep that in the back of your mind. I do provide at the bottom here also the dose equivalencies if you need to convert a patient from one agent to another. So for example, the S-citalopram is the enantiomer of the racemic formulation citalopram, so it's just half the dose because we're only giving half the drug. Fluoxetine 20 milligrams is roughly equal to fluvoxamine 75, paroxetine 20, And that's how that works. You can see the dose equivalency down here at the bottom corner. Okay, this is a kind of a bird's eye perspective on just the comparison between the classes of drugs and the category of antidepressants and their efficacy. It's not obviously the most comprehensive analysis, but it was done and published in the Lancet back in 2018. And I know that seems like a long time ago, but it's still true, right? You can see that a lot of these drugs have good overall efficacy, the odds ratio being greater than 1, so those who are on it receive some benefit. What drives us to pick one agent over another are the side effects and the cost. That's what typically drives it. When you look at SSRIs, which are up here at the top, the side effects are mild. I point out a few, and we'll kind of come back to those. I'll reinforce them. And now many of them are generic, so the cost has gone down, especially as other drugs have come out as well. So they're pretty cost-effective options that are relatively safe, except for the citalopram and escitalopram. If patients overdose is really where the issue is. So just keep those things in mind compared to the other agents, if that's helpful. All right, let's now give some consideration of some additional pharmacokinetic issues. We've been talking a lot about pharmacodynamics and their mechanisms and stuff like that. I mentioned a little bit about fluoxetine and its metabolite sticking around a long time. We talked a little bit about the interaction of other receptors and targets that can sometimes cause problems, but let's talk a little bit about the metabolic pathways that these drugs use. So we have our table here that summarizes the cytochrome P450 enzymes that make up phase 1 metabolic pathways, which a lot of the antidepressants use. You can see that we have substrates up here at the top, inhibitors here in the middle, and then those that are strong inhibitors, and at the very bottom would be inducers. I've tried to highlight for you in more bold those agents that fall into a particular row. So you can identify them kind of quickly compared to the other antidepressants that are out there. You can see that there are various isoenzymes, 1A2, 2C19, 2D6, 3A4 being the predominant ones that these agents can use. You can see a lot of drugs use 2D6. 2C19 is popular with some of these agents. Okay, you can see that, and some of them even are inhibitors of 2C19. We have mentioned earlier that fluoxetine and paroxetine were strong inhibitors of 2D6, and that can be very relevant for substrates that require metabolism through 2D6 to either become active or to be inactivated, which means that the effect can stick around for much longer. So keep in mind some of those 3A4 substrates, citalopram, escitalopram, again, small dependency, but could cause a little bit of competition for that pathway, but not significant. Fluoxetine's inhibition on 3A4 is not as strong as it is on 2D6. 2D6 inhibition is for sure relevant, and is something you should know. Okay, let's now talk a little bit about some of the side effects that this class experienced. Now, I've already kind of alluded to some of those, but I just want to reinforce some of them here in a summary slide. Okay, so it's like other classes in the antidepressant category. We have the anticholinergic over on the far left in the second column. You can see that most of them don't have that. They're not interacting. They're very selective for serotonin, so we don't see that. So dry mouth, constipation is generally not the problem. The GI side effects that you see here are more nausea, diarrhea related, the opposite. Again, there's serotonin in the GI tract, that's part of it. Insomnia, maybe a little bit with fluoxetine being a little bit more stimulating, as it has that metabolite that sticks around. It can start to accumulate, sertraline being one that fits in there a little bit. Sexual dysfunction, if you compare this with the other agents in the category of antidepressants, this is the one that's got the worst. And so there are other drugs that you may have to switch them to if this shows up. So like bupropion is a good option in the atypical antidepressants. If someone has developed SSRI-induced sexual dysfunction, some of the other atypicals like vilazodone, vortioxetine have also been potential options in there where they modulate the activity of other receptors in the serotonergic system that seem to blunt that effect. What I try to do also over here in the other is to highlight some of these things like the QT prolongation with citalopram and escitalopram. You know, escitalopram is the S enantiomer of citalopram, so it's just half of the drug and the racemic mixture formulation. Keeping in mind the drug inhibition of 2D6 with paroxetine and fluoxetine. We talked a little bit about the long half-life of the norfluoxetine metabolite that can be helpful but can also be problematic. And then sertraline is the drug of choice in pregnancy, probably has the better cardiovascular safety profile, whereas paroxetine is historically the one that was linked to PPHN in the newborn, so it's one of the reasons why we avoid it. All right, so we know that all medications have side effects, and some of them can lead to warnings and contraindications. Well, all antidepressants have a warning about suicidality. So that's one of our monitoring parameters, is checking their mood, assessing their risk for suicide, especially if you're using citalopram and escitalopram, because an overdose in this situation could be life-threatening, even though the other agents have a large therapeutic index. The other thing that's important to recognize and would be a contraindication warning is using this drug class if someone had already been on a monoamine oxidase inhibitor within the last 14 days. The risk of serotonin syndrome, it can be significant. If you're on fluoxetine and you're switching to a monoamine oxidase inhibitor, you have to wait 5 weeks, and maybe around 5 weeks, due to that long half-life of its metabolite being 4 to 6 days. So if you were on fluoxetine and you stop it, you need to wait 5 weeks before starting a monoamine oxidase inhibitor, because we just don't want to prevent that metabolism of those neurotransmitters and cause a hypertensive crisis or increased risk of serotonin syndrome in particular. So just avoid them. If they were on a monoamine oxidase inhibitor, you have to wait 14 days before you can start another antidepressant. Why? Because the monoamine oxidase inhibitors are irreversible inhibitors. So for the life of that enzyme, they're out. We talked a little bit about the dose and concentration dependent effects of citalopram and escitalopram on the QT interval. So if you have a patient with already QT prolongation syndrome or electrolyte abnormalities like hyponatremia, hypokalemia, hypomagnesemia, and hypocalcemia, so low sodium, low potassium, low magnesium, low calcium, then those conditions, including other drugs that are known to cause QT prolongation, may need to be used carefully or avoid their use because of that. And then lastly, these drugs can induce some mania, especially in untreated or undiagnosed bipolar disorder. So you want to make darn sure you have, you're not seeing the patient in a depressive episode, but have bipolar disorder, because you can make them hypomanic or even manic. All right, so what are some of the common monitoring parameters? Weight gain is an issue, changes in sleep with some of the agents, of course, assessing their mood, the various psychiatric symptoms that you started them on. You're going to have to probably ask about the sexual dysfunction. That is probably not something that the patient is going to volunteer. They're going to be embarrassed or think something's weird or think something's wrong with them or not even connect the dots. Why would they bring it up if they don't think it's a drug? So we need to be proactive and preemptive to warn them about this so that if it does happen, they don't feel like something is wrong and they don't know why. GI side effects, again, that nausea, vomiting early on may be relevant. Labs to consider, pregnancy test. especially if you are on paroxetine. Remember, sertraline is more the preferred drug. Sodium levels, especially in our elderly patients, that risk of SIADH can be relevant. And then watching out for new drugs that do get started because of the risk of drug interactions. So whether that's linezolid, tadalafil that has monoamine oxidase activity, whether it's a pain medicine like tramadol that also has some serotonergic activity, or someone starting another antidepressant and trying to mix them. You do want to be careful and cognizant of that. So from a counseling standpoint, obviously compliance with our medications is huge. We again reinforce the sexual dysfunction. If you're using it for anxiety, please talk to your patient. Please also start at a lower dose and titrate slower. I cannot tell you how many patients show up in the emergency department after their second dose or day or the third day of their new SSRI that's being used for anxiety. They told that it was being used for anxiety and it just made it worse. So these are very important things to counsel the patient on so they don't have to experience these uncomfortable scenarios or also encounter going to the emergency department and having a large, bill. Lastly is the drug interactions, especially with, if you're gonna start a monoamine oxidase inhibitor, you gotta wait, if you're stopping a monoamine oxidase inhibitor and you're gonna switch to an SSRI, you gotta wait that 14 days. That's key. All right, so, wow. We need to seek more than just information, guys. We need to seek medical understanding for a clinical application. Right? That's the how. So we know how to manage patients. Take this information when we understand why things are happening, like that citalopram. We know it's impacting that sodium and potassium channel in the heart. So you get QRS widening, you get QRS prolongation, or QT prolongation that can lead to torsades. That makes sense why I want to avoid it in patients at high risk for overdose. That explains the why. Why am I avoiding paroxetine predominantly during pregnancy? Because of the risk of PPHN. Now, it doesn't necessarily explain why that happens, but there's a connection there. There's relevance for the recommendation of why to avoid. Why is there an issue with waiting longer if you stop fluoxetine to start something else? Because of that long half-life of the metabolite norfluoxetine. It just makes sense and the application clinically more relevant. Now we have topics like this and other reviews and drug classes and other categories available at thisiswhy.health. You can bookmark, save those. You can get access to the tables for studying and your use for knowledge and education. Please feel free to check that out. So the SSRIs, first line, now many of them generic, cheap, effective options with large therapeutic indexes, except citalopram and escitalopram in an overdose. They're good. They're good options for both depression and anxiety. Okay, just if you're going to use them with anxiety, start out low and titrate slow. Don't forget fluoxetine, paroxetine, drug-drug interactions. That's cytochrome P450, 2D6. And lastly, no drug is perfect. They all have side effects. And sexual dysfunction is probably one of the most common issues that come up. So we need to be committed to talk to our patients about it, ask about it. All right, guys. Well, I hope you found this to be useful. Please subscribe and like us here at, if you're watching this on YouTube, and check us out at thisiswhy.health. And we'll see you next time. Take care.